A very warm welcome to the first Wednesday morning clinical meeting at the Department of Paediatrics and Child Health at the University of Cape Town. We're very excited as the Advocacy Committee to be hosting this event and opening it up to the broader child health and paediatric community, and to explore the ways in which we can rise to the challenge of extreme heat, and the ways in which that impacts on neonates, young children, and all the way through to adolescents. So we're particularly excited to have Nicholas Brink joining us. Nick is a clinical researcher based at Hoedspruit in South Africa, where he works for the WITS Planetary Health Research Program, whilst at the same time pursuing his PhD at Trinity College in Dublin. And his focus area is climate change attribution and exploring the impacts of heat on maternal, neonatal, and child health. So a very warm welcome to Nick, and we're really looking forward to your presentation.
Thanks so much, Laurie, and thanks for having me. Good morning to everyone. So today I thought I'd start off with a quote, and this is from Nelson Mandela at the launch of the Nelson Mandela Children's Fund nearly 30 years ago. He said, "There can be no keener revelation of a society's soul than the way in which it treats its children. It would be no exaggeration to speak of a national abuse of a generation by a society which it should have been able to trust." And I think most people are familiar with the first part of this, but the second part I only recently came across, and although in a different context and talking about a different atrocity, it really made me think of this generational struggle against climate change. And when we talk about child health advocacy, what really worries me the most is that these children don't really have a voice, and they put their trust in us. And I often think of the children that we're seeing today in the clinics, and when they start to reach our age or older, what society is going to look like. Often we talk about 2050 or 2100 as if it's so far away, but for these children, that's their future. And so I had a poll going, but I don't think it's going to work. So maybe everyone could just post in the chat. I thought I'd start with asking you what you think the greatest threat is to child health. I'm hoping there are not too many climate change converts in the group, but maybe just think beyond that for now. And hopefully, as these answers come through in the chat, maybe we can take the next step to start considering how can you link that to climate change. And pretty much without fail, when I think of these things, I think that almost everything, every person I speak to, they say, I don't know why you're studying climate change. Malnutrition is far more important. Infectious diarrheas are really a big threat. We're seeing a rise in antimicrobial resistance. There's not much that I can't say climate change is going to worsen the impacts. Either it's directly linked, or it is going to create conditions that are going to make it more difficult for children to adapt to that. And I think it's important to think of that when we think of the context of climate change and its impacts on children. There was a paper published in 2022 that showed there was a twofold increase in heat-related mortality in children due to climate change since 2009. And you can imagine how much that's changed. Unfortunately, data is sparse, so it's difficult to have up-to-date analyses. But they showed that there could be 6,000 heat-related deaths in children prevented by 2050 if we just met the Paris climate goals. It's 2025, and I do not think that that's going to happen. Last year, they officially confirmed that it was more than 1.5 degrees warmer, although that average still hasn't been hit. So today, I just want to take you through a little bit of the background to the impacts of climate change on health before we look at heat balance, then moving on to the spectrum of heat-related illness and how we might go about preventing that in children, and give a brief intro to how we might translate this to policy and practice, which will hopefully be picked up by some of the speakers later. So this diagram is shown quite often, and it's the World Health Organization's framework. And what it shows is how climate change has impacts on climate-sensitive health risks through individual and systemic vulnerabilities. And children really embody this quite nicely because they're one of the most vulnerable groups, and they're also a product of their society. They really rely on the systems for health to make sure that they can stay healthy. And we can see here at the bottom, we have some direct health outcomes that can be attributed to climate change, and heat-related illness is just one. So we really need to be thinking of all of these things and how climate change might be impacting it. And importantly, what impact it's having on our health systems, which are already strained. And this diagram kind of takes a slightly different view of it. And if we start on the left, it says that all of these climate hazards that we talk about, be it heat or poor air quality, they all exert their influence on a varying spatial scale. And that can be through something as small as the individual cell, escalating to organs like the kidneys, the brain, and can actually extend beyond the individual to have impacts on a societal scale. Those impacts can either be direct impacts or maybe more indirect impacts that can sometimes be harder to track. And these impacts might happen right now, or they could take a number of years, even decades, before we're really going to see the true impact. And so with that in mind, I thought that the best way to kind of get a good sense of what the heat impacts on children is to really take a deep dive into the physiology of heat. And so at its most basic, I think it's important to understand that heat really is measured by the core temperature of an individual. And that's what we refer to as the internal body heat storage. And that is a function of the heat that we produce and the net heat that we lose to the environment. And what's nice about this is it gives you a good sense of what the different ways we might lose heat, or in this conversation, actually absorb heat from the environment. I think often in children, we're talking about their risk of cooling down, but here, that same risk applies to them heating up. And we can see there are three chief mechanisms here. The one is through convection, which is primarily influenced by the air temperature, radiation, which is direct sunlight, and evaporative cooling. And evaporative cooling and convection can be modified by the wind speed. And so now that we have these three things, we have the temperature, we have sweating, we have sun exposure, and we have wind speed, we can start to consider what we can then do to modify this.
Morning.
And so if we take a closer look at how the body responds to this heat, through that mechanism of this internal body storage, the body then will sense what temperature it's in and respond appropriately. And this happens through both behavioral adjustments and through autonomic responses. Those autonomic responses are chiefly vasodilation and increased sweating. And I think these three things are really important because they give us a good sense of where children start to become more vulnerable. Specifically, children have a very high metabolic rate. That's physiologically the case, but also because they're running around. They're often far more active than adults. They have a high surface area to mass ratio, and usually this predisposes them to having hypothermia, but in the same instance, if it's very hot, they can absorb more heat. They have a very low adaptation potential. Children cannot remove themselves from hot environments. They often cannot modify their behavior if they're playing sport, for example. And they can't always find adaptation mechanisms like water or a fan. Physiologically, they have lower acclimatization potential. They have a low absolute blood volume, a lower relative cardiac output, and a higher sweat threshold relative to adults, which means that in a hot environment, they're going to struggle to adapt. So now that we have a good sense of how heat exerts its influence, we can start to consider the spectrum of heat-related illness. And we'll start with the direct heat-related illness. And I think this is what most people think about. And to be honest, for me, most people that I find them mostly thinking towards the severe end of the scale when we're talking about heat exhaustion and heat stroke. But really, the impacts of heat start with some mild things that actually can be quite burdensome to children and often are the reason for a visit to the healthcare provider. So very mildly, we might have a heat rash. Although heat edema is more common in adults, we sometimes can get it in children. This can progress to things like heat cramps or even heat tetany, which really is a hyperventilatory response to heat, where we get a respiratory alkalosis and resulting carpopedal spasm, perioral anesthesias, things like that. And only then do we start to move into the area of heat exhaustion and finally heat stroke, which is life-threatening. And so when we talk about what kind of signs we need to look out for, I think that it's important to remember that this is a spectrum. And I also think it's important to remember that a lot of these signs are the general danger signs in children. We need to be counseling people that heat is one of the things that can cause those danger signs, but we don't need to overcomplicate messaging. I think that we need to make sure that we're giving the same messaging, changes in behavior, changes in their physiological status that might be shown by respiratory rate or heart rate or core body temperature. Those things already are going to give us a good indication of where they sit on the spectrum. And I can't go through it all today, but I'd like to direct you to Up to Date, which has some lovely articles on this, on heat stroke, heat exhaustion, minor heat illnesses, what you might find and how you can go about treating those. And just scan the QR code. But beyond these direct heat-related illnesses, for me, it's so important to remember that this is just a fraction of the total heat-related morbidity and mortality. This graph depicts the causes of death during heat waves in Europe. And you can see only 23% is typically what we think of as heat-related illness. All of the others were excess deaths during a heat wave that were probably, in most circles, not attributed to heat. But we can see when we do excess death analyses that circulatory system diseases, people are more likely to die from, gastrointestinal diseases, infectious diseases, respiratory diseases. And in the context of children, I think that's really important to remember. And so when we think of the spectrum of heat-related illnesses that are maybe indirect, we can see that from a mild sense, maybe there's a change in the cognition of the child. There's an irritability in the parent, and that child then is struggling to focus at school, is starting to get into fights, and we see behavioral changes. We see an increased risk of food poisoning, infectious diarrhea because of the way food is stored. Conversely, these can then progress to actually making other systems more susceptible to inherent pathologies. Children with epilepsy might find there's an increase in their seizures. Children with heart failure or with respiratory conditions, whether they're acute or chronic, may find suddenly they're actually struggling to cope. And that's because of those physiological responses. The child is trying to cool down, and so it vasodilates and it sweats. And so you get changes in the electrolytes, you get changes in the plasma volume, you get changes in the load on the heart or the respiratory system. And those are really important to remember when we think of hot times and how they're gonna affect children. So now I think quickly we can look into some practical tips of how we might prevent heat-related illness. And to start, I think it's important to remember that this fits into a broader context. And the first thing, and I think this is something that's very unique to child health, is that we need to develop background resilience. And we talk about two things here. One is climate resilient development. We need to be making sure that in any development sector, be it education or sanitation, we're saying, how are you using this or responding to the future potential of climate change impacts? If you're building a new school to improve children's education, if you're not considering what color you're painting your roofs or whether you're going to install some low-cost cooling devices, you're really doing a disservice to future children. We know that if there's socioeconomic and health vulnerabilities, that children are going to struggle to adapt to the impacts of heat. But then we move on to some specific things, what we call first-generation interventions. Those are things like early warning systems, which hopefully you'll hear more about later, and what we call sustainable cooling interventions. And we'll go through those now. But we do need to think that there's a step beyond this. We're reaching a point where we need to start thinking about what we call second-generation interventions. Things like declaring a state of disaster. It's relatively common for other disasters where they say, oh, sorry, there's actually a severe storm and we think you should stay home. But for heat waves, it doesn't happen as often. And hopefully we can start to consider those to try and protect our children. And at the same time, we need to start thinking of second generation cooling interventions. And those are things that we need to start looking at to consider how we're going to cool people down when it gets even hotter, when they start to reach that threshold where they can no longer cool. And so keeping in mind that figure I was showing you about the internal heat storage and the heat balance in the individual, we really can be quite simple. We want to try and influence that. So you can move a child into a cooler area if possible. You can move them out of the sun into the shade. That reduces the radiation. We can increase the wind speed around them using things like electric fans, or if there's no electricity, just fanning a child with a book can be effective. We can, in a sense, create artificial sweat. You can douse yourself with a fine mist. You can use wet clothes. You can dip your feet or other highly vascular areas into water to try and dissipate that heat out. And all of these have their benefits. And we just need to make sure that the messaging we're giving to children and their caretakers is one that is appropriate to their context. I would love to put every child in an air-conditioned classroom, make sure that they have everything they need, but that's simply not always feasible. I've just put some links here to some additional resources. UNICEF has some lovely parenting tips that we can direct parents to. And the Global Heat Health Information Network has lovely resources beyond this if you are interested. And obviously always happy to take any questions. I think to end off, I'd like to just consider quickly how all of this would translate to policy and practice. And I think for us as child health advocates, what we're really trying to move away from is saying, you know, these climate change targets, they don't mean anything from a public health perspective to the average person. When we talk about a target of 1.5 degrees, which we're already breaching, or 2 degrees, I don't think people appreciate what impact that has. And so really what I think we need to move towards is a health-related target, just like we saw effective in the HIV era. And we want to see 0 children dying due to climate change. And that's a tall order, but that's really what we need to be aiming for. And to do that, we really need to start treating this for what it is. It's a humanitarian disaster. And we need to start pushing for the necessary public health authorities to declare this a public health emergency of international concern so that we can start to act in a coordinated way to try and prevent harm to this very vulnerable population. Thank you very much. I'm happy to answer any questions, but Laurie will guide us whether we keep those to the end.
Thank you, Nick. That was a wonderful presentation. Yeah, it really pushed us to think about what heat means at a physiological level. You really foreground what it means for children in particular, and their vulnerabilities versus the broader adult population. Yeah, so thank you for presenting that so clearly. I think it would be useful to probably move directly into Thandi's presentation, and then to field a set of questions and comments at the end. So Thandi, if you could put on your video and share your slides, and I'll just do a quick introduction. Dr. Thandi Kapwata is a specialist scientist in the Environmental and Health Research Unit at the Medical Research Council. She holds a PhD from the University of Pretoria, and her particular focus area is on the health and environmental impacts of air, water, and soil pollution and climate change. And one of her main areas of interest within that field is the health impacts of exposure to high temperatures and heat waves, with a particular focus on rural and vulnerable communities who often lack the resources to combat the health risks of heat. So a very, very warm welcome to Thandi. And we're really looking forward to your presentation.
Thank you so much, Laurie. Can you see me and can you hear me?
I can definitely hear you. I can see your slides. And if I scroll up to the very top of the list, I'm sure I can see you as well. Wonderful. Thank you.
Thank you so much. So I will just be giving you some more information around the impacts of heat and health, but with a focus on the sorts of interventions that the Medical Research Council is involved in. So just to start with, overall, we are seeing increases in temperatures across the country, rising temperature trends, increases in average, maximum, and minimum temperatures. And not only are we seeing rises in temperatures, but we are also seeing increases in the duration, the intensity, and the frequency of heat waves. So what that means is that we are seeing heat waves that are lasting longer, that are more intense, and that are covering larger geographical areas than they did before. Another thing that is of particular concern is the seasonal timing of heat events. What is happening now is that heat waves are occurring earlier in the season than they typically did before. And this is a risk because people are more vulnerable to heat stress when the heat waves occur earlier than they usually are because they have not yet acclimatized to the high temperatures. And so if heat waves occur early in the seasons than they usually do, that's when you see an increase in heat-related health outcomes. So this is just an image from the IPCC report from 2021. And what this does, it provides a nice summary to show the direction and the projected change of climate impact drivers in Africa. So if you just look at those first two columns, the one says mean air temperature and the other one says extreme heat. And as you can see here, both of them are projected to increase with a high level of confidence across the continent. And so what this is highlighting is that we are currently experiencing these heat extremes, and in all likelihood, the situation is going to worsen as time progresses. Also, just to sort of reinforce what Nick has already presented, the risks of heat waves to children. This is from the Lancet report, and they have an indicator called change in person days. And what this does is that it tracks the number of heat wave days per year per vulnerable person. And when we speak about vulnerable persons, generally it's young children and older adults over 65. And so what this shows is that in the period of 2012 to 2021, children younger than 1, so infants younger than 1, experienced about 600 million more person days of heat waves. Broadly, what this means is that each child experienced about 4.5 more heat wave days compared to 1986 to 2005. So we are seeing obviously very significant increases in the number of days that children are being exposed to these extreme temperatures. And of course, with that comes the concern if there's increased exposure, then there's the increased risk and severity of heat-related illnesses as well. So we have done some research in the spaces in which children frequent, and I'll just present a few slides around that in the next coming slides. So the first is health facilities. So a commonly cited problem within the South African public sector is the duration of waiting times. There was a study that showed that in district hospitals, the average waiting time is about 9 hours. So you can imagine you're spending 9 hours waiting if you're particularly in a rural facility, you're in an area without air conditioning, without fans, 9 hours with a young child. That is really a significant risk. So we monitored indoor temperatures in 8 clinics in Guyane, and that's in the Limpopo province. And as you can see, this is showing the indoor temperatures in these waiting rooms. As you can see here, the temperatures generally tended to be between 30 and 40 degrees Celsius, and that is extremely high temperatures. And so at the bottom there is what is called a symptom band table. And these are classifications by the US National Weather Service. they categorize apparent temperature into ranges, and then they provide some possible health risks that could happen if you're exposed to that temperature. The reason why we use these international symptom bands for our research is that unfortunately we do not have similar bands for Africa, and that is one of the glaring areas of research that need to be filled. And more worryingly is that these symptom bands are based on the physiology of adults, and as Nick explained in great detail, there's a reason why these need to be tailored to children, because the physiology of adults and children differs, the impacts differ. And so although we use these broadly, just to highlight the sort of risks that are possible, it is not very specific to children. And this is also something that needs to be looked into. So as you can see here, the temperatures really very extreme, very high, between 30 and 40 in these spaces. And if you recall the previous slide where I noted the report that said the average waiting time is about 9 hours, if you can imagine spending 9 hours in conditions like this, it is really very, very dangerous. Another problem is that obviously, in these spaces, sometimes there might not be water readily available. So that is also another significant concern with these long waiting times and high temperatures in these health facilities. This is just these are just some images showing the clinics. We also monitored heat exposure in classrooms because obviously we know that children spend a significant amount of time in classrooms. So we monitored indoor temperatures in schools in Giyani, Limpopo, and in Pretoria. So the urban schools, as we would generally see, had intact ceiling boards, tree shading outside classrooms, whereas the rural classrooms did not have these ceiling boards or lots of shading around the classrooms. So the maximum daily average apparent temperature in the urban schools was 32 degrees Celsius, but in the rural schools, it went to as high as 42 degrees Celsius. And that is a significant difference. And so there's a lot of evidence that shows that heat affects the cognitive function of children, the concentration of children. We're also concerned about an increase in the risk of absenteeism, to avoid hot classrooms. And there's also a lot of research that shows that as temperature increases, then, people become more irritable and more distracted, and this all can affect learning outcomes. So heat exposure in health facilities and in classrooms is a significant risk factor to children. So we've touched broadly on health risks and the impacts of extreme heat on health, but one of the ways in which we can protect people from extreme heat is through heat action plans, and heat health warning systems are part of this. So what a heat warning does essentially is it provides a heat alert, and that allows people to prepare accordingly for the heat waves, that allows for the dissemination of information and advice for what should be done once the heat wave begins. However, currently heat waves in South Africa are issued based on an exceedance of a historical high. So what that means is, for instance, when there's a heat alert to say that there's a heat wave coming in the next few days, so please adhere to the precautions, and they say, it's above 35 degrees Celsius. What that means is that for a period of 3 or more days, the temperature in a particular area will exceed the historical high. So that's the highest temperature that that place has ever recorded for a period of 3 days or more. But this is not necessarily linked to a health outcome. And what we are seeing more and more is that effective heat health warning systems globally are linked to a health outcome where, if there is a heat alert released, then there's also the information about, what possible health outcomes are linked to the exceedance of that threshold. So one of the things, though, is that to create these heat health warning systems and to test them, they do need a lot of data for health outcomes. So, generally, operational heat health warning systems will use either mortality or morbidity as a health outcome. So we have done some work around trying to identify possible thresholds that could be included in a heat health warning systems, and this is the publication from one of our projects. So the aim of this work was to provide a recommendation for a temperature metric and then thresholds for that metric. And so there are several metrics that can be used in a heat alert. You can use maximum temperature, minimum temperature, mean temperature, or diurnal temperature range. And that is the difference between the minimum and the maximum and the minimum temperature, sorry. And so what we found was that maximum temperature was the best predictor of mortality. So, that could be a very good indicator to use in a heat health warning system. And that is because maximum temperature represents the maximum thermal stress that can be experienced by the human body. And you will also see, if you look at the map there, that the thresholds vary across the country. So with the hotter areas experiencing higher thresholds and the cooler areas experiencing lower thresholds. So the threshold distribution sort of tends to follow climatic zones, and those are in that small inset map. I hope you can see that, but if not, then please, you can download the publication so you can have a clearer look at that map. So generally what we see is that, for instance, the hot desert area here, according to the climatic zone map, those areas tend to experience higher thresholds. And for instance, the oceanic sort of climate zones tended to have lower heat threshold. So what this means, though, is that when you consider heat risk or heat alerts or heat warnings, the risk is not uniform. And so you have to take into account regional variation of these risks. And just to give you an example of one of our current heat health studies, and this is led by the University of Cape Town with a host of other partners, one of which is the Medical Research Council. So this study is called HEPFIA, and it's a heat adaptation study. But we are also, it's a longitudinal cohort study where we are collecting health data around the physical impacts of heat on health and mental health and general well-being in Ghana and South Africa. So we have 2 sites in Ghana, in Kwantenkesi, and in Accra. In South Africa, we have sites in Thohoyandou and in Cape Town. And so what we're doing is we're monitoring core body temperature, physical activity, sleep, hydration status, blood pressure, glucose, body composition and weight, just to try to get a sense of the impacts of heat on health in a longitudinal cohort studies, because there are not many of those in Africa. So as part of the study, one of our interventions that we have implemented is cool roofs, where we have painted the roofs of the homes of our study participants with a reflective paint. And one of the advantages, obviously, of this reflective paint is cooler homes. And what we are hoping is that through these cooler homes, we can then improve the quality of sleep of children. We know that obviously getting good sleep is essential to the health and development of children. There's a lot of evidence that shows that less sleep in infancy and childhood has a significant risk to childhood obesity, and sleep habits in childhood also may impact weight into at adulthood. There's also research that shows that poor quality sleep in childhood increases the likelihood of emotional and behavioral challenges in early childhood. And so, this is so this intervention is a very It's a cost-effective intervention. And so we are now in the post-intervention phase where we are monitoring the efficacy of the intervention. And obviously we are hoping to see significant or notable reductions in health outcomes or overall, as well as in the general indoor conditions. So other adaptation strategies to reduce impacts, for instance, education and advocacy is really important. And these are some of the posters that we have distributed to health facilities and schools across the country. And this is a collaboration with the National Department of Health. So just some points for consideration as I wrap up. So we do need more focus on the development of heat health outcomes at localized levels. So, more region specific. And also we need these to focus more on the impacts of children. You'll notice that from the slides that I showed, all of those are, a broader classification of heat health and of thresholds, not focusing on children. And the reason for this, and Nick touched on this in his presentation, is the lack of data. There is, a general lack of data with regards to child health outcomes. And of course, if we are to develop heat alerts or heat warning systems focusing on children, then this is something that needs to be addressed. We also need more research into health indicators that are specific to children. So that when we create these heat alerts, heat action plans, we are focusing on particular health outcomes that we know are specifically suited to children. There's also a concern of underreporting and the incorrect classification of heat-related deaths and illnesses, and this makes it difficult to accurately estimate the true impacts of heat. And just as an example, so in the mortality data set from the Stats SA, there is a category X30, and that is for cause of death due to excessive natural heat. And, surprisingly, the number of deaths per year in that category is about 10 or so. And, given all the information that we have around the impacts that heat has on health, this number is very unlikely. And so this shows gross underreporting. Okay, I touched on this slightly, that we need to improve the quality of child health data. So, cohort studies, digital hospital records would also help in terms of helping us to be able to link specific health outcomes to specific heat exposures in children. We also need to focus on structural and systematic interventions to protect children from the impacts of heat in the spaces that they frequent. For example, heat-resilient healthcare facilities. So, either reflective, cool roof paintings is one, heat-resilient housing structures, more urban greening initiatives, those sorts of interventions. I mentioned the urban greening initiative because that in particular, urban greening obviously affects the microclimate, so it lowers the temperature of the immediate surroundings. And obviously as a consequence, then that makes the buildings around it cooler. So heat health effects are not limited to extreme temperatures. So it's important that the heat interventions that we focus on include both extreme and moderate temperatures. It's also important to note that heat does not act alone. So heat waves often come with high atmospheric pressure. And what this does is that it creates a stagnant layer above the ground level. And so it sort of traps pollutants at a layer that is more available for breathing. So the polluted air persists for longer in an easily accessible zone. And so that's increased risk of pollution on top of the impacts of extreme heat. So Yes, thank you very much. That is the end of my presentation, and I'll be very happy to take any questions that you might have.
Thank you so much, Thandi. We're very sad to hear that Bono Nemokulu is unable to join us from the National Department of Health today. She has a funeral to attend. So watch the space. We will try and invite her to join us at another engagement in the course of the year. But for now, what I'd like to do is just open up for questions and comments from the floor. If Thandi and Nick could just keep their videos on so that they're ready to field questions, and perhaps if Thandi could turn off her slides, that would be a good start. And I guess from my side, one of the questions I have is, to what extent are we aware of these challenges, or were you aware personally of these challenges and the potential implications for child health? And that's a question of around how awake are we and attuned to the science are we as a pediatric community? And then what are the implications? What is it that we can do, either individually or together, to rise up to this challenge, whether that's in relation to our research agenda, our clinical care, the kind of advice and information that we provide to frontline workers and or parents and caregivers, and in particular to children themselves. So opening up the floor and perhaps just starting off with a question from Priya in the chat, where she's asking, is there any consideration of cancelling sports in heat wave days and some adjustments to the usual uniform requirements? I don't know, Thandi or Nick, who'd like to field that?
Sure. So I'm not sure if the Department of Education has any specific guidelines around cancelling sports during heat waves, but I do know that a number of schools now tend to, they insist on hats, for instance. So there's lots of schools have this thing of no hat, no play. So obviously that's really important. And also many schools encourage parents to always put water in a water bottle for their children. And then they encourage the children to drink throughout the day. And I do know, I wish Bono was here to speak more on this, but the Department of Health is really engaging with the other departments around trying to highlight the impacts of heat on children. And one of the recommendations, as the person who asked the question there is saying, one of the recommendations is to try and shift sports to cooler periods, either early in the morning or in the late afternoon.
Thanks, Thandi. I think there's also some guidance around that in the National Heat Action Plan, but I'm not sure to what extent that plan, which looks so very good on paper, has been broadly disseminated or shared with schools. So that would be a question.
If I could add there,
yeah.
sorry, Laurie, and I think just to add, I think it highlights a really important point about the inequities between the public schooling system and the private schooling system, and where people do have those kinds of resources. So I know where I'm staying in Hoedspruit, the private school here has modified everything. Sports are in the early mornings. There are limits on when they can exercise. They provide them with all of those things. But then I think that's something that shows, like in a private system where they have all of these resources and they perhaps have access to the expertise, where they can say, how can we modify it? What are the practical things we can do? Whereas in the public system, because they're already strained, this is not necessarily a priority. And they're just trying to say, okay, well, actually, we've just started these sports and we don't want to then be told it's too hot in Limpopo today, we're going to have to cancel the sports. And that's when we talk about those second generation interventions as well, because what impact is that going to have when you're seeing exceeding hot days like Thandi was showing, that really you're going to have these severe limitations, and how are we going to respond to that?
Thanks, Nick. A question from Carla. Are we helping children age appropriately to understand and monitor heat and health-related effects, with the aim of including their voice in our research? that's a provocative question.
Yeah.
There's two different parts to it, the understanding part and the research part.
I think most of our research is shifting, and I think that although we're not really looking so much at clinical trials involving young children, there's definitely a shift towards this, where we're starting to involve people with lived experience, not as participants but as experts. And I think that's a really important shift, and I think that will be an important part of the children too. And we have to acknowledge that these children, maybe, yes, they do have a relatively limited understanding, and as Carla mentions, it needs to be age appropriate, but we do not need to start including them as the experts in how they experience this.
And maybe if I can just add to that, Nick, that in a lot of our research, especially in these rural areas, what we do first is we speak to the children themselves. You know, we try and understand how they experience heat, because we might be sitting here thinking, well, this is the temperature range and this is how you should be feeling, but how you should be feeling and how you actually are feeling is not the same thing. And so, you know, we do speak to them to get their perceptions of the heat, get their experiences of the heat. And then we also do a lot of education and awareness around what they can do for themselves, you know, to try and to mitigate against these sorts of risk. But definitely there is more that we should be doing, especially as a research community.
Thanks, Thandi. And of course, we're then also concerned, as Dave LaRue has pointed out, about very young children who may not, number one, be able to articulate how they're feeling, so may not be able to have a meaningful voice in the research process, and who are dependent on adult caregivers to keep them cool. So Dave is asking or saying, you know, much of our concern around thermoregulation in neonates has been focused on keeping babies warm. And is anybody working on messaging for our labor wards, postnatal care, kangaroo mother care staff in order to keep babies cool? And that would extend through to well baby and immunization clinics. And in asking that question, it reminds me of a very powerful presentation that Darshnika Lakulu presented at SAPA, at the SAPA conference. And she talked about how in Kenya, some babies who'd been very carefully swaddled in blankets had got so hot that their skin had peeled. And for me, you know, that's such a graphic image of what overheating could potentially look like. The ways in which we wrap and unfold and care for our youngest children, and how do we shift those practices and adapt to a changing world. So Nick and then Thandi, any reflections on that?
Thanks. Yeah, thanks, Dave. I think it's a great question. I mean, I suppose, yes, people are working on it, but are they doing a good enough job? Is it fast enough? I think the answer will always be no, even though we try. And I think that's what's so important about platforms like these, where we can say, how can you actually further that objective? And I see Ashraf's comment as well, that it starts in pregnancy, and that's our big focus too. And we know that you tell a pregnant woman that the heat affects them, it's the first time they've heard it, but the doctor also hasn't heard it, the healthcare provider. And so I think we need to be exploring every avenue we can. But at the same time, we need to be mindful of cultural beliefs. And that's something that comes up a lot in our research. We do a lot of ethnographic research, qualitative research. And, you know, we need to acknowledge that this is something, the swaddling of babies, the protectioning of babies is culturally relevant as well. And if we don't engage people as experts in this, why is this happening? What are the barriers? What are some perhaps culturally appropriate adaptations? The kind of messaging we do develop is going to fall, it's going to fall by the wayside, because it's prescriptive. And I think that's what's so nice about child health, is that it's an area where we've learned that we have to work with parents, we have to work with cultures to say, how can we actually protect these populations? And in a sense, the hospital system is a culture. I have a personal gripe with neonatal units and how they set their incubators, but you know, it's still a culture. It's still a culture, And I think we need to start shifting even the medical culture to say we need to start, thinking about these things in this new context.
Thanks, Nick. And handing over to Thandi.
Thank you, Laurie. I think what this raises is the importance of the co-creation of these interventions or adaptation measures, right? As Nick mentioned, when you speak about swaddling, for instance, in Guyana, when we were monitoring the indoor temperatures there in the clinics, like you've both mentioned, the babies were really swaddled in these thick blankets, and again, it's all about the messaging. It's about the way in which you relay the information. It shouldn't be prescriptive. We should be doing it together to say, okay, we understand that these are your concerns and these are maybe your practices, but how can we work together? So that we can indeed lead to lower risk for children.
Thank you, Thandi. And Marion, I think, has just also flagged concerns around breastfeeding. How do you continue breastfeeding when you're feeling unbearably hot and all that skin-to-skin contact? So at what time of day do you breastfeed? Are there things you can do to cool yourself and your baby before you breastfeed? So again, even when we're looking at infant feeding, heat has additional implications. I have another question of my own. In my understanding, the impacts of heat vary according to the humidity. So, for example, in KZN, where it's a whole lot more humid, 30 degrees is going to feel a whole lot more intense than it does here in the Western Cape with the sea breeze blowing in. And just sort of wondering if there's also kind of guidance around that in relation to those early warning systems that you were talking about. Thandi.
Yes. So I didn't really explain this in the presentations, and I'm sorry about that. So one of the temperature metrics that we look at when we speak about heat exposure is called apparent temperature. And this is a metric that includes humidity and wind speed as well, because like you rightly say, the temperature, if it's 35 degrees Celsius, the real feel of that is different once we incorporate all of these other variables like humidity and so on. And so most of our research, when we estimate the health risks of heat exposure, we tend to use apparent temperature. Other people also use an indicator called heat index, very similar. It also incorporates humidity. So you're right. I do think that these sort of heat early warning systems shouldn't focus on just one variable alone, but on variables that take into account other factors as well that affect the real feel of temperature.
Brilliant.
And
Thank you.
I can add,
Yeah,
sorry, if
ahead.
I can add, I think it's nice also to go back to those first principles when we look at why humidity has those effects. And the reason is that when there's excess humidity, there is an inability for us to cool down evaporatively. And so when we're considering the guidance on how we respond to heat, I mentioned dousing, putting on a wet shirt. That doesn't work if the humidity is above, say, 70%. And so we need to then consider, okay, maybe now wind speed is more appropriate. And when we're planning these adaptation response, providing guidance, it might change through the year. It may change whether you're in a specific part of the country or not. And so for me, it's really important to understand those first principles. It's the same with the fan. And, it happens, the temperature exceeds our body temperature quite often in this country. And so when the temperature outside is 40 degrees and you're blowing wind in your face, I think most people who have done that will agree that it's actually unpleasant. And that's when we start talking about these second generation interventions, because we're reaching a point where air conditioners start breaking down in the heat, and that happens in our hospitals. The air conditioner breaks down, we can't actually cool effectively, and all of the existing mechanisms just aren't going to work.
Yeah, so quite a sobering reflection. And I think really important to think about the interventions we choose and how sustainable they are. So thank you for flagging that, Nick. Thank you to Ashraf for highlighting that there's at least 5 to 10 meds that could, feed out or arise out of this discussion. I think there's a lot of work that we have to do as a pediatric and child health community. And I guess I had one other last question from my side around the Cool Roofs project. I know as far back as I think 2015, UCT did some research around cool shacks, looking at reflective paint, improving ventilation within the shack itself, or with an aim to cool things down. And yet when I followed up with them, that remained a research project. And somehow we haven't been able to translate this research knowledge into practice or to scale it up in order to protect children now. And I just wanted to get a sense from Nick and Thandi, how do we speed up this knowledge translation process so that we're not waiting for a cohort study to give us evidence in 5-10 years' time? How can we be a lot more agile and responsive to the threats that we face?
Yeah, thanks, Laurie. It's a great question, and I think for me that's why I ended with my presentation on a public health emergency, because for me it's not about the evidence. There's more than enough evidence here. There's more than enough evidence. We've got more than enough intervention.
You've gone mute.
Sorry, for me it's really about the political will. And that the white roofs is a good example. We went to the Green Climate Fund with an application to do large-scale sustainable cooling interventions in sub-Saharan Africa, and there's interest. We know it works, but the political will is lacking. Green Climate Fund only recently appointed a health person, a dedicated health person, and he's a department of one in a $8 billion initiative. And so for me, yes, we don't have time to generate that evidence, but that's what's so important about advocacy. We actually need to start pushing the political will. We need to start saying, actually, we have to act now if we're wanting to prevent, mass mortality of children in the future.
Thank you, Nick. And a last word to Thandi.
Thank you. So I think one of the reasons why we are particularly excited about this project, Laurie, is because it's one of the few studies that is actually monitoring the impact of these cool roof interventions on health. And so we are hoping that once we have this evidence and we can present it to stakeholders such as the National Department of Health, the Environmental Department, we'll have evidence showing that this intervention actually does have an impact on health. And so it is feasible. It is feasible for upscaling. Another thing, just to add to what Nick was saying about the cost of all of these things. Obviously, once we show that there already is evidence that these cool roofs do work. So then the question, like you were saying, is why haven't they been rolled out? It's cost. And so one of the things we need to look at is things like subsidies for having these sorts of interventions done on a larger scale in these heat vulnerable areas. And I think maybe the rollout doesn't necessarily have to be everywhere at once. We could use our research, to guide us as to the areas that are most vulnerable. And so maybe it could start in that way as well. So maybe proper planning, proper funding, proper resource allocations, those are all key to us rolling out these adaptations to move away from them just being, like you're saying, on research and publications to actually helping people.
Well, thank you so much for joining us, for sharing your knowledge, your expertise, and your passion for this work.